Alright everyone, this video is about asymmetry with the MSE appliance, which is to say when the MSE appliance expands one side more than the other. First, what I'd like to talk about is what is the prevalence of that. Second, what I'd like to talk about is what are the two types of MSE asymmetry. And then third, what I'm going to talk about is can we prevent asymmetry with the MSE? Is there a way we can guarantee a perfectly symmetric split, which is of course what we all want? So first, the prevalence of asymmetry with the MSE. I guarantee that it is not that common, but that it is not also extremely rare. I experienced it. I would say it's definitely not a majority of patients who get asymmetry, but it's definitely also not outliers only who get it. I would say it's a small minority of patients who have some significant degree of one side expanding more than the other. I'm one of them, and I also know another woman who reports having one side being expanded more than the other with the MSE. In both of our cases, interestingly, we had existing asymmetries that the MSE sort of exacerbated. My right side was caved in more when we started. I had more of a crossbite on the right side, and the right side proved to be the more stubborn side when expanding with the MSE. It didn't expand much, only 3 millimeters, while the left side, which had always been the larger side for me, expanded 7 millimeters. And the same thing happened with her. The side that was already caved in expanded less, and the side that was already wider expanded more. Don't know what's going on with that, but I think it's an interesting observation at least. Okay, so if there are any doctors who have treated with MSE, have had many cases, please tell us what you think about the prevalence of asymmetry with the MSE. Now I'm going to move on to what are the two types of asymmetry that can result from MSE expansion. There's going to be the tooth-borne kind, and there's going to be the bone-borne kind. The tooth-borne kind results from negligence, you could say, from lack of observation, from lack of paying attention by the orthodontist. The tooth-borne kind results from the fact that the MSE, when it's installed, has arms that come off of it and attach to the upper molars through molar bands. Tooth-borne asymmetry results when the MSE has screw drag and then continues to drag through the bone, transfers its force into the arm of the MSE, and then the MSE transfers its force directly to the upper molars on that side, causing those molars to flare out. The screw drag will happen only on one side. One side will be stubborn and the screws will be firm in there, and then the other side, the screws will, when you turn the appliance, the screws will cut right through the bone like a knife through ice cream cake. And then, of course, they'll transfer that force to the arms and then into the molars, and then boom, the molars on that side pop out from the expansive force of the MSE. How do you prevent that from happening? Number one, be aware of what the MSE is doing. Is it splitting the suture as you expand it? Or is it dragging through bone? Because what you'll see is you'll turn the MSE appliance and the appliance will budge. It will turn. Something is happening. But the question is the suture splitting or are the screws dragging? The only way you can know with certainty is by doing a CBCT. Do a CBCT and find out what's going on, because if there's screw drag, you've got to cut the arms off that appliance immediately. And really, you should be cutting the arms off the appliance as soon as possible anyway, according to the Ting protocol. Dr. Richard Ting recommends you cut the arms off the MSE appliance as soon as, I'm not quite sure what, but very early in the process, the arms need to come off to prevent this tooth-borne expansion. The other big thing you can do to prevent this type of asymmetry from getting bad is you follow the 1 turn per day protocol. Again, this is also the Dr. Richard Ting MSE protocol. You turn the MSE once per day, no matter what. And what this allows you to do is keep an eye on things. Things will not get out of hand this way. You can watch them develop slowly. If you turn only once a day, it gives you a lot of leeway to catch problems before they become exaggerated. Take it slow, know if you have screw drag, cut the arms off the MSE appliance. This will mitigate and minimize the first type of asymmetry with the MSE appliance, which is the tooth-borne asymmetry resulting from screw drag and arms pushing into molars. The second type of asymmetry is the bone-borne asymmetry, which is what I believe I experienced. This happens when the bone structure on one side of your face is more stubborn on one side than on the other, and the stubborn side acts like a brick wall, and then the looser side kicks off of it and expands more. So in my case, I had, I think, 7 millimeters of expansion on the left and only about 3 millimeters on my stubborn side, which is my right side. What causes this? Well, this type of thing must be caused by a difference in bone structure. The bone density or the bone angulation or whatever, the structure, let's keep it at that, the structure on one side of the face is going to be more stubborn than the structure on the other side, and the stubborn side will not expand as much. How can we mitigate this? So here we will talk about the dome procedure. The dome procedure is a type of surgical assist to the MSE, in which not just the mid-palatal suture, but other sutures in the face are cut in order to guarantee an MSE split. This procedure would be done during the MSE install. You break the mid-palatal suture, and then you break sutures right in this area. And this eliminates resistance to the MSE appliance, and the MSE appliance is guaranteed to open up symmetrically right away. Basically, you're making the resistance on both sides of the face 0, which results in a guarantee that one side of the face will not be more stubborn than the other because they are both at R equals 0. The problem with the dome procedure is that it forces you to let go of any possibility of midface expansion, which is a big reason many of us get into the MSE in the first place. Midface expansion is a critical component of the aesthetic advantages of the MSE appliance. It's going to take your midface, your cheekbones, and it's going to make them more 3D. It's going to make them pop out of your face more. But if you cut the sutures here, you cannot get midface expansion. Why? Because the MSE transfers its force to the midface through these sutures. So if you cut these sutures, you're cutting the circuit. You're cutting the circuit, and then force cannot be transferred up into these bones. So the dome, it does allow you to expand your airway. The roof of your mouth will expand. The floor of your nose, which is the roof of your mouth, will expand. But your midface cannot expand with the dome procedure. So it's a huge, huge compromise. But it will simplify your orthodontic situation because you are guaranteed a symmetric split and a symmetric expansion with it. The last note I'd like to say about preventing bone-borne asymmetry with the MSE, and this is pure speculation, but you could introduce possibly some outside mechanical forces, some orthodontic mechanical forces to assist the stubborn side. Orthodontics is just physics. It's mechanics. It's about adding forces to overcome existing forces. It's about breaking inertia. It's about moving bony structures, whether they be teeth or whether they be facial bone. If one side of the face is being stubborn and not budging to the force of the MSE, you could, in theory, just add a force on that side. So, for example, what about a face mask? A face mask with 1 or 2 elastics going to some TADs or even the MSE hook on the stubborn side and pulling it out in this direction. The face mask could be one way of introducing some additional force to help break that stubborn side. Another additional force you could consider adding is some elastics, some cross elastics like I've got, going from the inside of the stubborn upper to the outside of the stubborn lower, and then that elastic will add some some buccal torquing force to that stubborn side, and that force might help overcome the resistance of the bone on that side. This is pure speculation, but perhaps it's time for orthodontists to start pioneering some clever mechanical tricks for getting that stubborn side to budge during MSE treatment. All right, everyone. Hope you enjoyed that video. And if you have any ideas on preventing asymmetry with the MSE, please share them below. And I hope y'all enjoyed that. Catch y'all on the flip. Peace.